David, I only see 3 of us.
I only see 2, you and Manager Jones, who's the
Amit.
third.
Amit Motwani.
Oh, Mr. Motwani's. Oh, there he is. I apologize. His video's not on. That is a quorum, actually.
Is that a quorum for us?
Yes, sir. It's 3 of 5.
And now I have Sherry. So
yes, sir.
Ready to go.
You are ready to go.
Okay. Good afternoon. Today is June the 9th, 2021, and it is 1:01 p.m. As a quorum of the committee is in attendance via our video conference, I'd like to call to order the meeting of the Central Health Strategic Planning Committee. First item of business is public communication. Members of the public who wish to make comments during the public communication portion of this meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Yvonne, did anyone register to make comments?
No, sir. No one is registered to make comments.
Thank you very much, Yvonne. I will now go to proceed to the agenda. Agenda item number 1, review and approve the minutes of the May 12, 2020 meeting of the Strategic Planning Committee. Can I have a motion? I have a motion from Manager Valadez. May I have a second? I have a second from Manager Jones. Any discussion? All in favor?
Aye. Aye.
Any opposed?
And Mr. Chairman, my internet's rather unstable now, so I'll try to get my video back on in a little while.
Okay, no problem. Any abstaining? I didn't see any. Motion carries. So the minutes are approved. Agenda item number 2 is to receive and discuss an update on the proposed fiscal year FY 2022 strategic priorities, including systems planning for immediate service delivery focus areas, part 1, healthcare for the homeless and respite care, and B, specialty care initiatives. Monica Crowley will lay out this item and will introduce other speakers for specific topics. This item has a number of subparts, so there will be an opportunity for questions as we proceed rather than waiting until the end of all of the presentations. Monica, I'll give the floor to you.
Thank you, Dr. Bell. Monica Crowley, Central Health. And I would like to thank our partners from Community Care, Dr. Audrey Kwong, who is the clinical lead of Community Care's Healthcare for the Homeless program, and Josh Rivera, who is the practice administrator for the Healthcare for the Homeless site and many other community care sites, for joining us today. Also, Dakasha Leonard, our Service Delivery Operations Manager, Cynthia Gallegos, Service Delivery Operations Director, John Morgan, our Chief Operating Officer, Alan Shulsha, our almost full-time Chief Medical Officer in a couple of weeks, and I will be presenting today. As Dr. Bell said, this presentation is part 1 of 2 presentations that are the deep dives that we always present, or that we started presenting last year, related to proposed fiscal year strategic budget priorities. So this is part 1 of a deep dive presentation related to the proposed fiscal year 2022 strategic budget priorities related to the immediate service delivery focus areas that came out of our initial systems-based planning work. Part 2 will be presented during the August Strategic Planning Committee meeting. Next slide, please. As we presented to you in this committee in January, Central Health staff and some of our partners have been working since around June of last year on developing an equity-focused, systems-based planning effort that includes Central Health prioritizing and planning over the short, medium, and long term to ensure that complete care pathways are available for the low-income Travis County residents that we currently serve and that we could be serving. In January, we presented, I think we'd shown you this slide once before. In January, we presented the version that we developed through this work on the first phase of the work, which included identifying the components of a high-functioning, comprehensive system of care, key gap areas, and the prioritization factors that we were using to identify the immediate work that we would be recommending to the board. We also presented to you on what the next steps or the next phase of this work would be. And this is what we're completing this month. And it included further evaluating the gaps and disparities with our internal, looking at our data. We'll be presenting some more on this to you. Sarita will be later during this meeting today. And evaluating the prioritizations with our subject matter experts and developing proposals for immediate initiatives to start to address the gaps in the fiscal year 22 budget as we engage additional support for our longer term planning efforts relating to the comprehensive system. Next slide, please. And so, like I said, if you look at the bottom right-hand corner, and I need to learn how to circle things on these slides, which I have not done yet, but I'll just point it out here. Today, we are presenting deeper dives on healthcare for the homeless and the specialty care access, thanks Brianna, proposed immediate service delivery focus areas. Part 2 on behavioral health, substance use disorder, clinical and patient education and transitions of care will be presented in the August strategic planning meeting. We want to give you guys a heads up that later this month, when Jeff and Lisa present their initial presentation on the budget, that may include information on proposed priorities that we are going to be presenting our deeper dive to you on in August. But we wanted to let you know that we are committed to getting these deeper dives to you. And you may see some of these included in the initial budget, but we'll be coming back at the beginning of August during that first week to also do a deeper dive similar to the ones you're receiving today on specialty care access and healthcare for the homeless. Next slide, and I am going to hand it off to Dr. Shalsha to review our prioritization factors that we used for coming to these initial recommendations.
Thanks, Monica. Good afternoon. This slide is to graphically illustrate that our prioritization was multifactorial in nature. So as we approached our system-based initiatives, we utilized both objective data, patient feedback, subject matter experts, and care team experts in order to order or prioritize our initiatives. We looked at cascading events. So what can we do now that will benefit the communities that we serve later? And also tried to ensure that we're not overwhelming the same individuals with multiple priorities. This mixed together serves as kind of the key to moving initiatives forward. As we continue and as we receive feedback from our community needs assessment, and other input, we will augment factors and give more energy or less energy to those initiatives as based on the input that leads us in a specific direction. Monica, I'll hand it back to you.
Thank you. And based on these prioritization factors, two of the areas that rose to the top for immediate need to begin to address included healthcare for the homeless, including proposals around respite care and continuing specialty service expansions. And now I'm going to hand it off to Dr. Audrey Kwong, Josh Rivera, and Dakasha Leonard to present on the healthcare for the homeless proposals related to this presentation. Thank you. Oh, and next slide, please, Brianna. And Dr. Kwong, we can't hear you.
We can't hear you. It looks like you're unmuted, but we can't hear what you're saying.
Hi, can you hear us now?
Yeah, I can hear somebody now.
Yes, that's good. I can hear you.
All right, go ahead.
Can you hear me?
Yes,
Yes.
now.
All right.
Great. Well, thanks so much for having us and allowing us to share our work with you all. I wanted to briefly start by talking about the term healthcare for the homeless, because it is a term that we use and there has some background behind it. So in the 1980s, it was clear that persons experiencing homelessness were suffering more barriers than most in accessing care in the traditional healthcare system and even in the safety net healthcare system. And so in a sense, we needed a safety net for the safety net. And so two charitable foundations asked cities across the country to apply for 4-year grants to really reimagine what care should look like, could look like to best serve this vulnerable population. And from these 19 cities, we've really learned best practices. And that's what we've really tried to incorporate in our program here in Austin, and also found some gaps in care, which we'll talk about. Next slide. So if you think about the healthcare landscape that you and I have, it's really just us, the patient, our primary care provider, and maybe some specialty care or a hospital. For someone who's experiencing homelessness, this is what it might look like, that they will access care wherever they can, whether it be at the hospital, the ER, going to community agencies, going to the shelter, mental health facilities. And it's often the individual accessing care on their own, and these systems of care really not talking to each other. Our hope over the last few years has really been to bring all these groups together so that we are coordinating and integrating our efforts on the patient's behalf, that they don't need to come to us, that we should be going to them and working on their behalf. And so hopefully that this has sort of evolved over the last few years. And the next slide is an example of this. So this is unfortunately a patient who suffered frostbite from our winter storm in February. I saw this individual at the Palmer Event Center, which was a shelter that was put up pretty quickly to house over 400 people experiencing homelessness downtown. And this particular gentleman I saw Friday night, and he was way worse than many individuals I had seen. He had low blood pressure, fever, did not look well, so I sent him to the hospital. Saw one of our colleagues, Dr. Mercer, who is working as a hospitalist, also is on our care team, and admitted him, was actually COVID positive, and made sure that he was hydrated and given antibiotics. He stayed in the hospital about 2 weeks and unfortunately was discharged to the street, but we let our street medicine provider, Matt Hunt, know about him, and he found him on the street a couple days later. His wounds started to open up. One thing that I didn't know, and the patient didn't know, because we just don't treat a lot of frostbite, is that usually after 3 weeks, that's when the wounds start to open up, that the deep tissue injury starts to come up to the surface, and you'll start to see the skin break down. So he immediately called over to our Care Connections clinic. Our podiatrist, Dr. Peel, saw him the next day, did some wound debridement, tried to get him in, but the patient refused because he was worried about all his belongings in his tent. And so he was discharged, but promised to come back Monday morning. Unfortunately, he did not come back Monday. So we informed our partners on the community health paramedic side to please look out for him. And they found him on Wednesday Thursday. We were able to get him admitted to transported to Delseton. I did make a call over to Veronica's team, who said that they would welcome him to stay at the nursing home, but wanted to just get him cleared by the hospital first. So we sent him over to the ER. A couple hours later, I happened to just call over to the ER, and they said, "Oh, he's being discharged because he doesn't want to stay." And so at that point, I asked them, please don't let him go. Let's get a site consult. He doesn't understand. He actually thought that the hospital made his feet worse, because he said, "I went to the hospital in early March and my feet got worse because of you guys." Clearly did not understand, the pathophysiology of frostbite, but just also very paranoid and scared. So he stayed at Delseton, had a surgery consult. He refused the amputation. Our partners at Central Health were willing to bring him over to Heritage Park for observation, and so he stayed there. Unfortunately, his feet didn't get better, and he had to get some toes amputated. But I believe that if it wasn't for this care team across all our different agencies and the communication that we had, that he could have lost a lot more, and even his life. So I really think this is a great example of care across the continuum with our team, with the hospitals, with community health paramedics, specialty care, with Central Health. And just a shout out to Central Health. I had encountered at least 10 people over the March-April timeframe who unfortunately had to get amputations of feet and legs, sometimes both legs, and many of them had to unfortunately get discharged to the street from the hospital and the nursing home. And when I reached out to multiple partners, whether it was the city, shelters, it was Central Health that answered the call and was able to put at least 10 of these individuals in their boarding cares and their nursing homes. So thankful to Veronica and her team for really answering the calls for these vulnerable patients. Next slide. So currently our Healthcare for the Homeless team is made up of 4 different sites: our Arch Clinic, our mobile team that goes to fixed sites each day of the week, our street medicine team, and then our hub site, our Care Connections Clinic. Next slide. And I just want to do a deeper dive into our Care Connections Clinic. That's our newest site. Similar to the principles of Healthcare for the Homeless, where you just really want to make everything really easy, accessible, under one roof if possible, we've really tried to build that out at this site. Where we have our eligibility specialists who can enroll you into MAP on site. We have Carol, our wound care nurse, who can provide wound care. We have intensive case management, who can help people apply for SOAR and benefits and food stamps. We do some high-level things. We've got some hospitalists on site who can do paracentesis, IV fluids, keep you out of the hospital or prevent you from going back to the hospital. And we can even provide some specialty care like Hep C treatment, so you wouldn't have to go to a special clinic. So if you think about all of these different sites, you would potentially have to go to 4 or 5 different clinics to get this care, but this can all be delivered under one roof. And I just could ask Dr. Shelsha to maybe talk a little bit about our podiatry services that we provided, because it's such a beautiful thing, and I really love Dr. Shelsha's vision for bringing on podiatry into our clinic.
Thanks, Audrey. We actually wanted to share a little bit of sad news with everybody today. About 2 weeks ago, Dr. Peel very unexpectedly passed away. We had multiple team members that actually attended his funeral in North Carolina this past weekend. He was from a small farming town. He was an academic. He was a clinician. He was a celebrated surgeon. We will honor him here. His mom created a scholarship, both as an organization and by way of individuals. Folks have donated to that scholarship. We also have 6 internships, Houston Tillotson internships here at Community Care, and those will be renamed in Dr. Peel's honor. He was most excited about the continuum of care, that he was going to be the first person to conduct surgery in Seton and in the ambulatory setting, and be able to transition patients from outpatient to inpatient and then back again, helping to ensure that they didn't fall out of that care continuum that Audrey's talking about. We will do our best to honor his legacy. And so we will continue to push forward with podiatry and with wound care. He set the stage. I mean, he's pun intended, but he has very big shoes to fill, and we'll do our best to honor him and most importantly, honor the patients. Thanks, Audrey.
Yeah, thank you. All right, next slide. Just wanted to say that there's also some special sauce involved, that while we talk about our sites and the care that we bring, it really is the people that is the special sauce. That our team is built up of members who have a desire for true heartfelt connection, respect for all fellow human beings, and interest in working with people on their priorities at their pace, meeting them where they're at, and then understanding that housing is essential to health. And so really pushing for that piece, recognizing that we can't do a whole lot without housing in place. This is just a picture of a gentleman that we had the privilege of taking care of for several months, was in the IC for over a month, multiple admissions for heart failure. We got him into the Pro Lodge in early January, and he was so thankful. He actually said he rarely left his hotel room because he was too scared and really wanted to take good care of himself. And on March 26th, he successfully boarded an airplane back to Croatia to be with his family. We are thankful we had a chance to take care of him, and this is us at Care Connections with our case manager, Amy. Next slide. Just really quick, wanted to also talk about how our team was able to pivot during the pandemic. And again, same philosophy of care, meeting people where they're at, especially for persons experiencing homelessness, not able to access the things that our city had put in place for testing, for vaccinations. So the first top 3 slides are our team members at different settings. On the left, our street medicine team; in the middle, in the community at Sunrise Church; and on the right, transforming the garage at Arch into our testing center, testing over 100 people per day for COVID. And on the bottom left was us going to the Pro Lodges, providing care at the different hotels week to week. And then the bottom 2 on the right are us providing vaccines in our community. These were at Arch. So next slide. And then again, another principle of healthcare for the homeless is that community partnerships are critical. And so these are just some of the partners that we have developed deep relationships with. And you can see from that example I shared how when we all work together, we can do really great things. Next slide. So these are some of the gaps in care. As we look at some of the best practices for healthcare for the homeless and what other cities are doing, we've looked at what do we have and what do we hope to bring to Austin or build out even more. And so these are some of the things that we identified: medical respite, expansion of our street mobile team, increased case management services, expansion of CareCo, and then improved access for mental health. We're really just going to focus on the first 3 today, and maybe get to the other 2 on another time. So next slide, I'll talk about medical respite first. So why is it needed and what is it? So respite care is short-term residential care that gives someone a chance to rest. So if you think about if you ever got hospitalized, when you leave, you can go home, you have your meals, you've got a place to take your medicines, you can call if something's not going well, a place to do wound care, and then you can get in your vehicle or a vehicle and get back to see your provider. But if you think on the left, this is a discharge of someone experiencing homelessness, and all the red X's signify a barrier to care. So when they get discharged to the street, they won't be able to take their meds, they won't have meals, regular meals, they won't be able to call if something doesn't happen, they won't be able to do wound care, there will be no transportation back to anywhere, to a doctor or to the hospital, and it's very, very, very hard. For that reason, we see that that the readmission rate for someone experiencing homelessness is up to 50%, and that in general, people often stay longer in the hospital, up to 4 days more. So what respite would look like to the right is if someone were to be discharged to a place, could be a shelter, could be a hotel room, just anywhere safe that's not the street, that they would have a place to, take their meds, and there might be a provider coming to check in on them. There might be a nurse who would be on site to help them figure out their medications, do some med teaching, call for their follow-up appointment back to cardiology or to the surgeon. There would be a social worker that might help with arranging transportation, helping with some of the benefits that they might be entitled to, and then a mental health provider to start to look at some of their needs on that end. And so this is what respite could look like and what we hope we can bring to Austin. Next slide. So on the left is some local data. So for one day at Del Seton Medical Center in 2019, we counted up 109 patients who were experiencing homelessness on the medicine service. Of those 109, 24 patients, or 22%, were people who were experiencing homelessness of the total patients. When we looked at how many people came back within 30 days, it was 54%. So that was in line with national data, and that was only to Seton hospitals. So it could have been actually much higher if they went to St. David's or a different hospital. And several of these patients, at least a sixth of them, had frequent ER admissions. One patient had 11 ER admissions within the last 3 months. So that's local data to say what is happening in Austin. To the right is a randomized control trial, one of the few that we have, of how respite can improve outcomes. So the dark blue bar graph bars are people who got into respite, and the light blue is people who tried to get into respite, but there were no beds. And this study occurred in Chicago. So it was it was a controlled study of those who got into respite and those who didn't. And when you followed up these individuals for a year, those who got into respite after 1 year had less inpatient days, less ER visits, and then more outpatient visits. So that's actually what we want. We want people to hopefully get into care and not use the hospital or the ER. And so this is some really great data to show the benefits of respite care. So next slide, I'm going to turn it over to Dakasha Leonard to share with us a little bit more about the specifics of what we're looking at in Austin.
Okay, so a lot of you may have heard of a new entry, as they are a chemical dependency treatment facility here in the Austin area. However, they also have a non-licensed recovery center in which they're offering us 20 beds to start our pilot there. The services that they provide will include an assessment done by an RN, the bed, 3 meals and snacks, access to laundry, and supervision. They have trained security within their teams. Next slide. So any funding requests that we make will include use of a new entry staff to support the program, as well as a designated medical respite team, which will include a registered nurse with some type of wound care or emergency room experience, a community health worker, and LCSW, LCDC, something of the sort to help patients navigate after their treatment for any type of residential services, legal services, or any assistance they may need. I'll turn it back over to you, Dr. Kwong.
Okay.
Next slide.
So I'm going to turn it over to Josh to talk about our mobile street medicine team.
Great. Thank you, Dr. Kwong. Really the big takeaways of why we need mobile and street medicine is because the nature of our clients or patients, right? People experiencing homelessness, they either don't go to care or they utilize the wrong resource. As you see over on the right, we estimate about 40% will use the hospital as their primary care. Thankfully, 28% use the clinic, but I think what's also staggering is 21% choose to not engage in care. We know that a lot of that is because of different social factors, whether it be stigma, past experience in the hospital or clinic system, distrust of the system in general. I think we really saw that exacerbated with the pandemic and even now, politically speaking, with some of the movement with the camping ban, right? It's going to be really important that we have teams to be able to capture these patients that hopefully are already engaged in care, but if not, have a way to meet them where they're going to be, which I know there's a lot of question marks still. But again, it's about being nimble and being flexible and being prepared. Down below, you'll see a picture. Man, it's been a couple years now. I know that those are some tough weeks. That was our response to Hurricane Harvey, again, illustrating how our mobile team and street medicine teams are so flexible that we're able to jump at the call, jump right in, set up operations within a few hours, and begin seeing patients and meet their needs. Dr. Kwong alluded to the winter storm out of the Palmer Event Center, and as well as the pandemic drive-through testing was the mobile and street team that really got that off the ground for community care. Again, thanks to our team members and flexible nature and being able to be pretty malleable. Next slide. So what the current component looks like, we do have two separate operations. You have mobile, which we consider teams that go out into the community and establish clinics in community partner space, and our street medicine team that goes out in one of our passenger vans and actually provides care curbside or wherever the patient is at, essentially. That includes encampments where we know that there's drug use sometimes, under the overpasses. More or less, if you've seen a group of tents together in Travis County, it's a good chance that we've been there. We try to divide up our day, north, central, and south, or our week, rather. We're excited that we're able to provide MAT services, so substance abuse disorder services, through our nurse practitioner who has the appropriate waiver to be able to prescribe Suboxone then and there. And even if we're not available, our partners at CHP are able to provide naloxone to help aid overdoses, as well as get them on a dose of Suboxone until we can get there. Our mobile team is right now provides 1 day a week service at Community First Village, which we're really excited to hopefully grow along with them. They've announced their phase 3 and phase 4 for their growth campaigns, so we're hoping to increase our presence there in the upcoming months and years. We've been partners of Sunrise Church, the weird little church over in Menchaca, as they like to call themselves, for over 3 years now. We've been a stalwart there every Thursday, and that's really kind of where the idea of the perks that CHP put together, where all the resources come together, didn't matter what agency, to really capture our homeless population there. So we're proud to be kind of the founding members of that. Camp Esperanza, if you've heard of our partners at the Other Ones Foundation, Camp Esperanza is the state-sanctioned camp from a year or so ago that has really grown and flourished into something beautiful. There's a lot of uncertainty of who was going to administer that space. Governor Abbott kind of handing that space, that state land over to be a legal camping place. And we've really seen that transform into something that really follows the model that the Grahams have laid out at Community First Village. I know they're now and I know Dr. Kwong actually practices out there. They're in the midst of putting little mini apartments or mini homes with little AC units that patients are being assigned to. And again, we have a presence there 1 day a week, providing services out of their rec center. Terrazas Library right there next door. If I don't know if you're on site at Central Health or not, but you may have seen the RV actually out there on Wednesdays serving that population at and around 35 and up and down Cesar Chavez. And of course, the Pro Lodges, even though they're more or less coming to a close, it really was fortunate that we had a team that we were able to send out to the various Pro Lodges to actually meet our patients while they were housed for that little bit of time to get a lot of patients stabilized and on care and on track. And then, of course, we talked about our COVID testing and now vaccination efforts for our healthcare for the homeless population with Johnson & Johnson, the 1 dose. Next slide. So the future, right, for mobile and street, what could another team do? Obviously the need is growing even as we speak now. The camping ban really, we anticipate it being strongly enforced towards the end of the summer. Of course, we want to be able to support the medical respite program that Dikasha and Dr. Kwong talked about. That could be some of the staff that make rotations through there, inclusive of a provider. And again, support from supportive housing programs. Before the pandemic, we were working for our partners at ECHO to potentially provide services as they work through the PSH process to provide medical services, because their founder, coming from Colorado, had a very similar model. Targeting hospital discharges, I think, is going to be really critical, and kind of where the piece of case management that Dr. Kwong's going to talk about shortly comes in, how we can better coordinate with our case management partners, whether they're embedded or at least have that access to that information of who's being discharged. Targeted populations is on our radar. Of course, we have one of our specialists, Dr. Mike Stefanovitz, who taking over as lead at David Powell, really interested in how we better serve our patients on the street with HIV and who are homeless, who may not be able to get to David Powell, or again, because of stigma or fear or experience with the healthcare system, just don't want to engage in that way. And of course, continued COVID support as we navigate through the rest of the pandemic. So what's the team look like? Ideally a provider, a nurse, 1 to 2 medical assistants, which can be cross-trained to have front desk experience, especially with our powerful tool with Epic, additional case manager, and again, some mental health or CHW support would be what the ideal team would look like. Next slide.
All right, and I'm just going to close with one other need, which is case management. If you look at the right, this is sort of all the factors that go into our health outcomes and into our basic health, and it's, for me, very humbling. You look at all the different things. Clinical care is only 20%, access to care, quality of care, each 10%. But what really makes an impact on someone's health is addressing social and economic factors, physical and environment, and health behaviors. And so for that reason, especially with this population, addressing their social determinants is so critical. So the traditional role of a clinic case manager is to assess their needs and link them to resources. In a health clinic, that might look like scheduling appointments, helping with transportation, and providing some help with finding what's out there and how to do it. And they're recently expanding more to addressing social determinants of health. But what that looks like in our healthcare for the homeless environment is a little bit different, because it has to be, because our patients have limited communication. They don't have phones, so you can't call them. They can't get places as easily. They don't have the social support, family members bringing them and helping them. And there's a higher prevalence of severe mental illness and addiction. So what that looks like is it has to be assertive and persistent outreach. That we can't wait for people to come to us. We have to jump in and help, and that often means bringing people to places, sitting with them, so they don't get frustrated, and really, again, focusing on social determinants. Next slide. Next slide, please. This is Lauren, our case manager on the top right. She is absolutely wonderful. This is with her patient Joyce, who she brought to Care Connections about 1.5 years ago. She previously was living under the bridge at 7th Street. She was able to help her apply for Social Security income through the SOAR process and get expedited approval within 90 days. They are taking a picture at Community First Village, where she was housed, and then help her apply for a lot of other things, get some medical needs addressed. And so this was her when she was with a different organization, that we were able to bring her over to community care. And Lauren has, I don't know, she's probably up to like 13 or 14 applications, with one of the highest success rates of SOAR in Austin. And so doing really amazing things. And Richard Johnson on the bottom right, he's what we call our COVID vaccine ambassador. He's a community health worker as well, sort of meeting clients, patients, helping them get excited about getting the COVID vaccine, making sure they came back for their second when we were using the Pfizer Moderna. So really just out in the community and being very flexible and again, meeting patients where they're at. Next slide. So this is just an example of one of my patients out at the state camp. She's 60 years old, severe heart failure, multiple hospitalizations, and one day when I was seeing her in clinic, just come out of the hospital, and I was, in my 10 minutes, listened to her heart, like, bad heart failure, okay, you need these meds. And that's all that I could say and do. But my case manager jumped on the phone, called HEB, got the meds delivered, started the paperwork for all these things, called her Central Health case manager, coordinated their care, got her re-enrolled into MAP, started an SSI application, called over to Integral Care. And then I was like, wait, I think she needs to be admitted. And so then at that point, the patient's like, no, I can't be admitted. I won't go to the hospital, my stuff, my dog. So then our case manager's like, no problem. She called the Austin Animal Shelter, got her dog picked up and dog safe, got the Other Ones Foundation to get a lock on her stuff and put her stuff in, so to keep it safe so it wouldn't get stolen. And then she agreed to go to the hospital. So I just think about like the things that I can do and what I was trained to do, and in comparison to what a case manager can do and all the things that this patient needs, which was very little of what I could offer, but very much all the things that this case manager could offer, all within like an hour. And that often takes longer than that, but just to show you this example. And so really, I think it speaks to us being able to address not just the medical. We shouldn't just be addressing the medical. We should be doing more than that. And what that means. I mean, I think I often have the easiest job of just coming up with a care plan, but it's all the things that have to happen after that I think is the trickiest part. Next slide. This is something that our team has put together over the last few years of all the different things that we want to address. And this speaks to social determinants of health, that a person's health is not just made up of their physical health. All of these different parts contribute to their health, and all the agencies in our community that we should leverage off of and build relationships with so that we can really give the best care to our patients. Next slide. So in summary, to the right is this graphic that comes from Healthcare for the Homeless of really just how we've envisioned care for persons experiencing homelessness and all the different components. And so today we touched on the 3 red circles: case management, medical respite, and street and mobile medicine. There's a lot more, and things that we are doing well and things we could still continue to build out. So in conclusion, people experiencing homelessness are medically and socially complex, highly vulnerable, and disproportionately have higher morbidity and mortality. Our current healthcare system is unfortunately fragmented, often fragmented, provider-centric, and ill-equipped to address social determinants of health. Our current system does need medical respite. We need more intensive case management, and we need mobile street medicine teams to answer and address some of these needs. And an integrated multidisciplinary approach is needed to improve outcomes for these patients with multiple complex needs. And next slide. So these are some of the proposed initiatives for 22, and I'll send it back to Monica.
Okay, and John or Alan, would one of you guys like to walk through these initiatives just really quickly, and then it's opened up for questions?
Sure, I'm happy to touch on these very briefly. Good afternoon, managers. Thank you for your time this afternoon. So in support of the work that you all have heard about today from Dr. Kwong and Josh and Dakasha, there are some significant investments that we need to make in healthcare for the homeless, how we engage with our homeless population, the medical respite services that we mentioned, and some of the supporting services. You just heard Audrey end her statement, in her presentation with a discussion around case management. Some of the specific things that we're looking to do in FY22 around this healthcare for the homeless priority focus area is acquiring a mobile unit for supporting our street medicine teams. They really need a purpose-built vehicle to make their service as effective as possible. There's a good opportunity that Community Care is actually going to be able to likely fund one vehicle using some additional grant funding that they received related to COVID relief. But as you'll see, we're also proposing to add additional street team capacity. So this would be a second vehicle to outfit for that additional street medicine team, that additional capacity that we would bring online. Which takes me to my third bullet. One of the things that we've identified as a gap with Audrey and Josh's help is that we need better access to infectious disease for our homeless individuals receiving care at CareCo. They're often introduced to those services through a hospital admission, and for the ongoing treatment of our patients with IV antibiotics, we need to have enhanced access to infectious disease at our CareCo facility. And then you heard about medical respite with Takasha. This is an effort that we've been pursuing for several years, and quite frankly, we've had several swings at this and several misses. It's a particularly complex service. It's not a service that a lot of providers are really eager to get into, but it's an incredibly important component of the system and a gap that we need to fill. We're very fortunate with the provider that's expressed interest in working with us on this in FY22. And we're fortunate in our systems planning effort, we actually had a separate initiative that was identified, or gap that was identified, that we need a safe respite space specifically for our women enrollees and for those who require wheelchair accessibility. And it just so happens that through this medical respite solution that we've identified, we can also fill those gaps as well. One thing that does not appear on here, I will say that did appear earlier in some of our internal planning documents, was that we need additional capacity for CareCo itself, for our complex primary care unit, mainly due to space constraints, but also just in the amount of time that it will take for us to set it up. We moved our CareCo expansion, or a second CareCo location, from an FY22 initiative into FY23. So just want that to be on the members' minds as we're talking about this, that we are continuing to think more in terms of multi-year comprehensive programs versus single-year initiatives. So as much as we can, we'll try to highlight what's in some of the out years, and we'll be continuing to work with our consultants and through our systems planning initiative to sequence all of those and make sure that we've got them on the calendar in the right place. Happy to help answer questions as they come. Thanks.
Okay, Monica. I guess that concludes part A. So first of all, I'd like to thank the presenters, Monica, Dr. Kwong, Ms. Leonard, Mr. Rivera, Dr. Shalsa, Jonathan. That was an excellent presentation. I marvel at how we have developed strategies to treat the population, people experiencing homelessness. It is, in my mind, amazing because they have complex medical needs as well as complex social needs. And you put those together and really it's a difficult puzzle to figure out, but you guys have done a great job and I truly, truly appreciate it. This time I'd like to ask members if they have any questions or comments that they'd like to make of the group with regard to this initiative. I see Manager Valadez. You're muted, Manager Valadez.
Okay, let me start by asking. I noticed that there was in one of the early slides, it says north. Is there only one facility, and is there only one space north? Is that what that means? I was trying to figure that one out. And the only reason I'm saying this is because my internet is also going in and out. It's not very steady apparently, but I wanted to know if somebody could explain that to me. And then I'm gonna go on. There's just some real quick things.
I'll start, Manager Valadez. So as we were talking about the capacity that we have that's really tapped out at this point at our existing CareCo location for complex primary care, we really need a second location. The current service is really covering more of the southern half of the county and the southeast half of the county. And we're looking for another location that will better serve our patients that live more in the northern part of the county. We haven't really looked in detail at a specific location. And in fact, if the Hancock Center moves forward, that may provide a really excellent opportunity for us to program some complex primary care services in that facility where we would have other more specialized clinical services in that location as well. So that's one of the reasons why that conversation's been delayed to some extent, is we want to make sure we do that analysis and get it right.
Thank you. Also, what is meant by non-licensed recovery center? And what does that mean with respect to liability? I think that you don't have these pages numbered, so I can't see what pages. It says respite in Austin, and it says new entry has a non-licensed recovery center. What does that mean?
That just means that they're not licensed as a chemical dependency. That particular location, yes, is not a chemical dependency facility.
Okay, so that it's not like a liability issue or anything.
No, it's licensed as a shelter.
Okay. And are they going for licensure under recovery to be able to address the needs of the people that are chemically dependent? Or are those going to be moved to a specific location, another location?
They will be moved to a specific location. They have another location in Del Valley.
Oh, okay. Thank you very much. And also, I just wanted to make a comment. You know, as we were describing this and their abilities to access services, and then after being released from the hospital or discharged, you know, they have access to all these things, care, supports. Well, I know lots of single parents with multiple children that don't have any of this, or men that are living in one space together who don't have any of this. And at some point in time, I'd like for us to perhaps look at how it's not, to me, the homeless do not have a structure around them. And that may be, their description may also be what some of our families, poverty also have, but except for the fact that they're not on the streets, but they also have things like that need to be considered. And I was wondering at some point in time whether we're ever going to look at those things with respect to MAP, to CHAP, and to BASIC. That's just a comment off the top of my head. With respect to the funding, there has been, I would say, close to $100 million has been allocated, and the bonds that passed, and the city and the county and other agencies, funding agencies, have allocated services. How are the funding levels for services to the homeless population being coordinated and looked at, so that all the people, y'all are at the table, and this is what we're saying we're going to take care of, this is what we're saying we're going to take care of, all the entities saying that this is what they're going to be responsible for, so that there is no duplication. Funding is tight, monies are tight, but we want to make sure that there's no duplication of funding and services, rather, that's being provided, so that we all take care of our piece of the pie. For us, I know it's anything other than 200% FPL, but I want to make sure that we also have the other entities that talk about social determinants of health, that talk about this, that talk about that have gotten bonds and dollars approved and allocated. How are we coordinating with those agencies so that we're not alone in all of this? Because I know we're never alone, but I want to make sure that we're all working together to coordinate. How is that being done?
Mr. Geisling, did you want to address that?
Yes, thank you. And thank you for the question, Manager Valdez. Right now, there's an effort that has a lot of different agencies at the table, us, the county, the city, as well as some nonprofit entities. And right now, and I'm probably going to oversimplify this, but what we're saying while we're at the table is we are going to continue to invest in the lives of those persons who are experiencing homelessness. And we think within the MAP population that's probably upwards of 11,000 individuals, and that's those that are chronically homeless, on the sheltering on the streets, but also those that have significant housing instability. And so, we're going to continue to do that, but really focus on everything that you've just seen here today. It's the care connections, and really stay in that healthcare space. And realizing that, yes, there has to be coordination points with these other entities, but to keep from, having duplicate funding or maybe overly redundant efforts, et cetera. We're focusing on the healthcare piece of it, and then those essential coordination pieces that are so critical to amplifying what that healthcare is capable of doing and being in folks' lives. So that's the overall strategic approach. There's a lot more technical aspect to that, but I think that's something I'd need to bring some additional folks to the table to help answer some of the questions from those other agencies.
Yeah, because I'd be curious as to what Austin Public Health is doing for the homeless population, and also how are the monies, the bonds that were passed being spent to make sure that they are being taken care of, these 11,000 at least plus, which is not even including the people that are living in housing shortage situations, where they're clumping together. And I don't know how we're handling that. How are we monitoring that aside from going door to door? I don't know how we're handling that. Maybe we could consider having a discussion about that at another opportunity. And I want to thank all of y'all for the presentation. And I also want to make sure that we get into those new encampments that are being developed. Like I see the one over here, of course, that I see every day, but the one at Pleasant Valley and Cesar Chavez, right there behind the lumber yard and IBC Bank, that goes all the way from the bridge to the 183 bridge. And I want to make sure that somebody's back there kind of monitoring them, because they are encampments also. Thank you.
Thank you, Manager Valadez. I appreciate it. Manager Musaitis.
Thank you so much for the presentation. It's great to see you all. Mine is really quick. First of all, thank you for the additional sauces and the human connection with this vulnerable population. And I think having that connection and empathy and really understanding their needs is essential for this work to move forward. Medical respite actually has been a discussion. I think we've discussed it several years ago, and my ultimate dream was to turn Health South into that facility. Unfortunately, things fell apart. Now, one thing that I'm concerned of is data interoperability. How are we going to access the readmissions? We personally, as far as I know, we do not obtain that information from the hospitals. So that's really a concern of mine. I think the outcome of it is more reducing readmissions. And how are we going to track these our homeless individuals in terms of really achieving that outcome that we want? Again, thank you for this initiative, and that's much needed. Thanks.
Well, I'll get to you, Chair Greenberg. Is there anyone that wants to address Manager Musaitis' question?
I apologize. You broke up on my end, Manager Musaitis.
Yeah.
What was your question about how we're tracking outcomes of our work related to the homeless population? Is that what your question was around?
Well, yes. And I think that's the outcome for respite. And I think the study that was presented to us in terms of the benefits of respite care is really ultimately reducing these readmissions. We don't want these homeless individuals to go back into care and ultimately have poor health outcomes. So how are we going to be able to track that information? Is that data available to us?
So some of it is, and some of it we're still developing. I think it's a great question, and I'll actually preview that you're going to get a refresher presentation and a subsequent agenda item from JP and Sarita, and I think that will help answer the question. But very generally, I'll say that what we're trying to do in the systems planning work and in taking an equity-based approach to this work is that when we're looking at health outcomes, whether that's readmissions or how well we're controlling someone's blood pressure or how well someone is accessing a particular service, we're trying to look at not just our overall population, but the different subsets of our population, whether that's based on race or gender identity or on homeless status or on documentation status. So when we are looking at outcomes, when we're looking at clinical quality measures or at readmissions, we are trying to take the time that we have not always done previously and look at those different measures for our subgroups of our population and not just the overall population, so that we can report specifically on how those outcomes were achieved for our homeless versus our housed.
Well, that's great, but it did not answer my specific question. So
I may have still missed your question.
I think I'll take a shot at it if that's okay, Chairman Bell.
Sure.
Thank you, sir. And I think Audrey was also trying to speak, but I think we're getting more data than we used to, but there's still holes, right? We work in these disparate environments, and so investment in our case management and care coordination is a step that Central Health has already taken, and one that we will be investing in more as we build out the transitions of care, because until we really do have these fluid systems, we're gonna have to handhold patients from one system to the next and manually seek out that data and just govern the patients by people, because otherwise folks are gonna fall through the cracks. I'm not sure if Audrey has anything to add to that.
Right now, we do have the ICC, which is the Intercare Collaborative, where I have access to it, and I've done some reviews on some of my patients at CareCo, where you can take every patient and it'll show you if they've been admitted to St. David's, Seton, Baylor Scott and White, if they've accessed care at People's, Lone Star. And so it is right now, it's pretty comprehensive, at least for now, to look at readmission rates. We're hoping to build that out some more, but that's at least an initial stab of looking at if someone has gotten readmitted in Austin.
Thank you, Dr. Kwong. Sarita, did you want to add anything? I saw your hand.
I did. I wanted to mention, Manager Musaitif, that readmission rates are a specific metric, right? And you need several data points in order to calculate a real readmission rate. We need to understand index admission relative to that follow-up admission, and whether that index admission was one that was planned, that follow-up admission was one that was planned. So there are lots of different pieces of data that go into calculating a readmission rate. However, I do know that our case management, medical management team are working with one of my staff to understand, if not those specific readmission metrics, the return of our homeless population in terms of looking at them as high utilizers and understanding why they may be coming back. So that work is being done. It's not necessarily, we don't necessarily have the data for all of our hospital facilities, but it is being done with the data that we do get.
Yeah, I'm sorry, just really quickly, for that readmission, are you measuring in terms of 30-day readmission rates, 90, so that time?
And so, exactly, and that you're presenting another complexity to that metric as well, because you can measure relative to 30 or 90-day readmissions. And as I said, because we don't have all of those components of the metric that we might need, again, understanding, we want to censor those patients who expired on their index admission. We want to make sure that we're censoring patients who came in as a planned admission. If they came in for an oncological visit to get their chemo, for example, we don't want to necessarily count them as a readmission because it was planned. So all of those little pieces of data are data we'll need to actually do those metrics. And we may not have all of those pieces yet, but our group is looking at admissions and subsequent admissions that happen relative to an index, but that rate, that readmission rates as it's defined as that validated metric, isn't something that we can easily get to. But work is being done in that regard.
Thank you. Thank you very much, Sarita. Chair Greenberg.
Yes, thank you. And I want to thank everyone for the tremendous work and a wonderful presentation. It was certainly illuminating. And a couple points. One, to Manager Valadez's point, I think when I speak of people experiencing homelessness, I speak of a continuum of homelessness. And my understanding is at Central Health that, in fact, we have a larger count, if you want to use that term, than, for instance, ECHO has with a point in time count, because my understanding is when we are visiting with our patients, if they self-identify as experiencing homelessness, then we include them. And so some of them could be what we would call couch surfing. They could, to Manager Valadez's point, it's my understanding that some of our patients who we are including as experiencing homelessness actually are housed, and but that if they are, for instance, couch surfing for more than 30 days, then we're including them as experiencing homelessness because their housing situation is so unstable. So we do have a broader definition and a larger number that we're including at Central Health, because we are not just including those who are unhoused on the street when we speak of people experiencing homelessness and how we're serving them. So I did want to point that out, and also to say that we, of course, want to do the best we can to provide services to those who are experiencing housing instability. And I know that we're continuing to work at that. It can be harder to identify because they're not as visible, right? You know, they're not in shelters, they're not on the street. But one way is that they're self-identifying to us. And so we do have that broader definition of people experiencing homelessness. We may not be picking up.
I just have to, I just want to thank you, Sherry, for understanding where I was trying to go with that. I brought it up in the past, and I thank you. And
yes, you're welcome. Yes, you're welcome. So we'll keep working to the best of our ability to try and identify and serve those who are very unstable in their housing. Also, I think that a point that Manager Musaitis made on data and outcomes is very important. And again, not easy, but I know that ICC, as was discussed, is doing more. Also, there are a couple of efforts that I know of that are underway with folks at University of Texas and also at Del Med to try and pilot and do research on combining additional data sources with what ICC and ECHO has to see if we can better track outcomes, whether it's hospital readmissions or other outcomes. So thank you very much, and thank you for all of your efforts. This is very important work, and I know it's not easy work, so thank you.
Thank you, Chair Greenberg. Manager Jones.
Yes, thanks very much. I just have a couple of comments. First one, I'd like to compliment the group on an excellent review. I think this was very not only professional, but also personal in terms of helping one to connect with the population that you serve. So often we talk about homeless, but we really don't understand what it is to be homeless. And you definitely do, with all of your outreach efforts, all your unique approaches to getting this population, to be commended for the work that you're doing. Second thing I just wanted to acknowledge is that I think there was some discussion about coordinating with the city. I think that's a very important part that has to be done. All of us have our different components, the city, the county, the district, the state, and others. But we do need to make sure that we're facilitating that, because many of the persons that we service go through each of those systems. And if we don't have a way to monitor that or keep up with that, even though they might be getting services, they may not be the appropriate services, and they may not be really making a difference, but actually complicating the problem because we don't have that consensus. So I would encourage that we work as best as possible with the city, the county, and others to address that. The last thing I just wanted to ask you, I think Manager Valadez indicated about the locations of the facility. One was south, and you said you were looking at a location maybe north, somewhere around the Hancock Center location, given the proximity of perhaps operations over there. I would encourage you to, if you want to do there, fine, but I would encourage you to look more north and east, because that Hancock Center is not necessarily conducive to the northern and the further eastern part of the community as well. So those are the three things I would just wanted to highlight, but to compliment you on the great work that you're doing and to encourage you to continue. We're here to support you in those efforts.
Thank you, Manager Jones. Greenberg, I want to make one comment first. Dr. Kwong wanted to let us know that she had patients to see at 2 o'clock, so she has left, but thank you for the opportunity to be able to provide the presentation to you. Chair Greenberg.
Yes, just one other quick comment on the coordination. I concur that this is extremely important. And to Mr. Gieslin's comment, you know, we all have our particular lines of service, and ours is healthcare. So to your point, Manager Valadez, that's where our focus is on the healthcare for those in our community who need our healthcare most, whether they're experiencing homelessness along that continuum or elsewhere in our community. So that's where our line of service is healthcare. Others in the community, when it comes to those experiencing homelessness, may be providing housing, food insecurity, and others. And to Manager Jones, it is important that we do communicate and coordinate. And on that, I want to give a shout out to Ted Burton and his team for their continual work on coordinating communications among the various governmental entities. Thank you.
Thank you, Chair Greenberg. Any other questions from the group? Manager Motwani.
Of course, I want to echo all of the commentary around what a great presentation this was. Is my audio available? Thumbs up.
Yes, sir. Yes, sir.
Great. And I think it's fantastic to hear such a sincere, poignant, and just eloquent testament to the value of addressing social health determinants from a physician, you know, a provider. It's really meaningful to hear that. And secondarily, just a question around, and certainly this could be followed up offline. Like, what does it cost to scale up each team? Is it, you know, I guess personnel and then all in? Is that like $1 million a team? Just so in the back of my mind, I can start kind of like doing cost benefit analyses, or all of us can be, I'm sure, whether they're raw or not. Thanks. And be happy to follow up, just receive that by email or a quick call or whatever. Thanks.
Okay, thank you, Manager Motwani. Mr. Morgan, I think you have a comment?
A very, very quick response to Manager Motwani. That will be the focus of our presentation on the 30th, and we'll dive into some of the dollars associated with these different initiatives, but wanted to focus on the strategy and the substance of the initiatives in this meeting today.
Thank you. Chair Greenberg, please.
Yes, I know for our newer members, you know, this is all leading up to our budget. So we're really very much what you see now, whether it's in strategic planning or our meetings or budget and finance, we are rolling out lead up to our budget. So these presentations that we'll get from Jeff Knodel at other meetings are lead ups to that. And then in the budget, we'll be getting that really type of line item financial information to accompany these presentations, whether it's on new programs, existing programs, 5-6 year forecasts, so on and so forth.
Thank you, Chair Greenberg. Any other questions? Okay, Monica, I'm going to turn it back over to you so that we can go into Part B.
Thank you, and thanks, Brianna, for advancing I guess, maybe 2 or 3 more slides. We need to go past the, keep going to where it says discussion. 2 more. Next slide. Okay, there we go. And then I'm gonna hand it over to Dr. Shalsha, John Morgan, and Cynthia Gallegos to go over our specialty care access proposed priority initiatives. Thank you.
I'll quickly turn this over to Cynthia, who's going to lead us through the beginning of the presentation. I'll pick up at the end, but just wanted to let the board know we're going to try to pick up the pace a little bit here. I think we're a bit behind schedule and have some other important agenda items on for today as well. So Cynthia, will you kick us off, please?
Thank you, John. Good afternoon, managers. I am really excited to co-present with John Morgan and with Dr. Shalsha, so thank you for having me. I am going to lean on this slide as an agenda slide. So basically, the way that we're going to break out the next slides is is capturing the information through one bucket of work called clinical capacity expansion, and then another bucket of work called specialty service expansion. A couple of things to note as we start looking into the clinical capacity expansion is that there are a couple of reasons in which these service lines are surfacing to the top. One of those reasons is that these are likely areas in which we have put previous efforts into, and because of that, it has now generated additional need. Another reason that we would likely be focusing in on these areas is that they are likely single provider service areas. Therefore, kind of, the wait lists behind them are oftentimes higher. And then lastly, just in general, some of these areas oftentimes just have a higher wait list, regardless of them being single provider service areas. And then really quickly on the specialty service expansion, some of these already look familiar to you, two of those being podiatry and dialysis. We will dive in further to those two, as well as some new initiatives that we're really excited to present here that are listed as bullet 3 and 4 there. So we can go to the next slide. So a couple of things, what we know about clinical capacity expansion. More than 20,000 MAP and MAP basic enrollees are diagnosed with 2 or more chronic diseases. We also know that reducing wait lists and improving access to specialty services in the medical homes is an important component of timely diagnosis and management of chronic diseases. So something to note is that each year, what we try to do is that we try and partner with partners across the healthcare system to expand that capacity, as well as to introduce new models of care, all to try and reduce the wait times that we have historically worked with. So for FY22 in this space, we have a couple of proposed initiatives, a few of those being that we would like to partner with community care as well as other community specialists to add additional capacity in the clinic space. We also want to work to provide enhanced care team support and to expand the use of the technology for the referrals as well as for the e-consults for those specialties in which it is appropriate for. A couple of exciting things to note, just while we're on this slide, is that community care has recently hired their second podiatrist this week. So we're really excited about that as part of the work to move this forward. A reminder is that we have, community care has their second endocrinologist starting come August. So that's a really critical piece of work for this next fiscal year. And then another really exciting piece of news is that community care was able to get their HRSA application approved for the new services in the neurology space. We can move to the next slide. So podiatry services, definitely an area that we've spoken to in previous presentations. What we know in this area is that timely access to podiatry services is important for Central Health's 13,000 enrollees that are diagnosed with diabetes. Within the last couple of years, Central Health has worked with community care to start introducing this service line as well as wound care services in the primary care environment. For this next fiscal year, Central Health is going to continue building upon some of the foundational work that we've done in these last years to really create the infrastructure, including expanding the clinical capacity as well as getting the surgical podiatry work off the ground as it's related to the diabetic limb salvage work. And I think with that, on this next slide, I will be passing it over to John Morgan.
Thank you, Cynthia. Managers, I've got the last 3 slides of this presentation, and then we're happy to answer questions. You all have heard quite a bit about our work to bring outpatient dialysis online for our MAP patients. You know, this has been a priority for us in FY21, and as we've mentioned before, we have several of these comprehensive programs that are really multi-year efforts, and we have to continue building on the progress each year. To get specific here for just a second, we've got about 35 MAP enrollees at any point in time who have end-stage renal disease in our patient population. In prior years, that number was significantly higher, but due to the work of our Central Health case management teams and our case management teams at Community Care and Seton across the system, there's been a large effort to get those individuals enrolled in permanent ongoing third-party coverage, either through Medicare or Medicaid, through the American Kidney Fund, or into Sendero, which provides our patients access to ongoing dialysis and potentially even transplant services in certain circumstances. What we're trying to do here this year and into next year is established outpatient dialysis services for patients who are in transition while we're trying to get them enrolled in longer-term third-party coverage. This is a very exciting effort for us. We're starting to see the pieces come together to bring this service online. As you all know, today, ongoing or outpatient dialysis is an exclusion for the MAP benefit program, and we're working with our partners at Ascension Seton to make that change. I should note that initially, Seton has declined to participate in this program in terms of a sharing in the cost or in providing in-kind services, but I need to provide the update that they have agreed to reconsider that, particularly for the part about providing vascular access for our patients and approving some of the program changes that we would need in order to stand this up in the MAP program. Outpatient dialysis is absolutely critical to these patients in terms of their mortality, their expected life, as well as their quality of life, and the ability to provide these outpatient routine services even allows some of these individuals to start working again when they haven't been able to for years. So you all know the critical nature of this service, and we're going to do everything we can to bring this online before the end of the year, and then focus next year on scaling up that service and optimizing the processes and transitions that are inherent in this program. I should point to the chart here that although we're really focused on these 35 at any point in time, the work of next year is also trying to get a little more upstream in terms of preventing the progression of of chronic kidney disease and even preventing that. So this does tie into other clinical initiatives beyond just the dialysis itself, but this is going to remain a priority for Central Health as we're proposing going forward until we get this program in place. Next slide, please. This is the first of two areas I'll cover that are relatively new focus areas for Central Health that we're proposing to start in FY22. The first is in cardiology in two different areas. I'd say one of these is at a population level, and one is really focusing on our most complex and highest risk patients in the cardiology specialty area, or those patients with congestive heart failure. Overall, hypertension is one of the 4 clinical areas that continue to show up across each of those component areas in our systems planning work. Hypertension, diabetes, obesity, and cancer care, particularly in the screening and diagnostics aspects of cancer care. But in terms of hypertension, that's about a quarter of our MAP and MAP basic population annually, or a population of more than 20,000 enrollees that suffer from hypertension. As you can see, our Black enrollees are 1.75 times as likely to have hypertension as the rest of our enrollee population. That's pretty significant. In addition, our homeless population is more likely to be diagnosed than those who are housed. Cynthia already spoke about the cardiology clinic expansion earlier in the presentation. We're also going to be focusing this year for the higher level population, looking at cardiology diagnostics. This is echoes, this is ECGs and treadmills. Right now, those diagnostic services are typically only available in a hospital-based environment. So this is adding enhanced access in our care homes where our cardiology clinics now live. So providing enhanced access to our patients, we lose fewer patients in transition, and we're able to more timely diagnose and effectively treat our patients in the cardiology service. And then related to our most complex or highest risk patients, we have a small population of congestive heart failure patients who require a higher level of case management and transitions of care, typically starting with when these patients are in the hospital for heart failure, making sure that they have timely access to follow-up. These patients need to be seen within 7 days of discharge and have routine, uninterrupted follow-up care in the primary care and in the specialty environment. So this environment is really about having warm handoffs between different care environments and making sure that we're fully wrapping these patients as they're moving from one system into another. Last slide, please. So this is the last area that we're proposing to introduce in the specialty care space for FY22. We're very excited about it. It's not an area where we have done a ton of work in the past, but it's critically important as we think about managing the care of our patients with chronic conditions, as we think about the population health of our enrollees. As you can see, more than 40% of our MAP enrollees are either diagnosed with obesity or meet the clinical criteria. And there is a higher risk for our Black and Hispanic enrollees compared to the overall population. Obesity continues to rise to the top of the list because of its contributing nature to other chronic conditions. It contributes to other chronic disease prevalence, and it also contributes to the complexity of treating different chronic diseases and even non-chronic diseases. We have patients today who would otherwise be candidates for knee or hip replacements who cannot receive those procedures because they aren't able to get their weight down to an area where they would qualify. So we need to be able to offer medical weight loss services in addition to the work that we've done in the past to introduce dietitian services and incorporate dietitians more into the care teams in the primary care environment. Again, medical weight loss is not offered today, very similar to our conversation around dialysis. And this pharmaceutical assisted weight loss, in order to be effective, we have to pair it with access to dietitians and also access to behavioral health counseling in many cases. So going into FY22, we hope to partner with one or more of our FQHC partners, with 40% of our enrollees potentially being eligible for this service. We are certainly going to have more demand and referrals for the service than we're going to have access day one. So we'll have to have conversations with our providers as we're developing the service on creating the referral criteria, the eligibility criteria for who should be referred up front. Additionally, we're proposing that within Central Health, we introduce a dietitian community health worker model that does not exist today and would be a pilot for us here internally at Central Health. So these would be dietitians and community health workers who are creating dietitian support that is disease specific and is outside of the clinic environment. So trying to get outside of the four walls of that interaction with their care teams and provide support in the home, provide support telephonically, and provide support in a culturally appropriate manner. Looking forward to answering questions. I would just like to acknowledge and recognize the work of our team, who clearly put in a lot of thought and effort and analysis into this work. A lot of folks involved other than those that you heard from in the presentation today, for sure. We're thankful to have such a highly qualified and dedicated group of colleagues to engage in this planning, and then more importantly, to move this work forward next year. Happy to answer questions.
Okay, thank you, John Morgan, Monica again, and Cynthia for that presentation. I do want to welcome Dr. Brinson, Manager Brinson, who's joined us. Thank you very much. I know how busy everybody is, so I appreciate you taking the time out. I'd also like to say before I open it up for questions that I'm really excited that Central Health is looking at preventive strategies with our population, both on the chronic disease side, chronic kidney disease side, and the medical weight loss. We do more for the population that we serve in trying to prevent some of these diseases than we do trying to treat it after individuals already come down with them. So I applaud you on that. Also want to say that Dr. Shalsha had to leave as well. He had medical opportunity or responsibilities that he had to take care of, but he appreciated the opportunity to present to you guys. I saw Manager Musaiti with a hand, so I will turn the floor over to her, and then I see Manager Valadez.
Well, thank you. I really appreciate it. And thank you, Dr. Bell, for mentioning that peace, prevention, and that's up in my alley as a public health practitioner, what we want to strive for. My quick question to you, in terms of the medical weight loss, how are you addressing nutrition, especially to these vulnerable populations who are living in these food desert areas? You know, I think what you have is great, but if we're giving them this nutrition counseling, but if they can't afford or have access to healthy foods, how can they achieve the optimal health? That's really my question. Thank you all.
I will try to answer that question, although I am certainly not the subject matter expert in that area. But completely agree with what you're saying, Manager Musaitov. I think the goal is that we would supplement the medical weight loss with dietitian services, with community health worker services, both by investing in additional dietitian capacity in the primary care clinics. It's one of those areas that we've only introduced in our primary care environment in recent years, and is not really not adequate for the amount of demand and for the prevalence of obesity in our population. But it's really this dietitian community health worker model that we're proposing to stand up here at Central Health and pilot is what will allow us to really get creative with meeting the dietary needs of our patients. I think at first we're going to focus on some of these complex or higher risk patient populations that we're proposing to work with in other areas. So our congestive heart failure patients, our end-stage renal disease patients who have chronic conditions that require specific dietary plans. So we will try to develop dietitian support materials, even coaching and counseling for those individuals that's specific to their dietary needs. I don't know every scenario that we will run into. In fact, we've got, I think, Veronica, our Director of Medical Management, and Jim Brown, our Associate Chief Medical Officer, are both on the meeting. They interact in our patients' homes with them every day. And they could probably speak better than I can to some of the individual needs that they run into. But I think by bringing this team in-house at Central Health, we're going to be very closely tied to it. We'll have the ability to be more flexible and to do what's necessary to meet the needs of those patients. The other piece, other than working with our higher risk, more complex patients, is the dietitians and community health workers can also work at that population health and prevention level to develop additional curriculum that we can use more broadly with the overall population, with people who are hypertensive, with newly diagnosed diabetics, or with those pre-diabetics, people who are at risk for developing it. So I think we're starting with education, and I think by bringing the team together here at Central Health and outside of the clinic environment, we're going to learn a lot, and we'll be able to come back to you all likely with requests for enhancements down the road to meet those unique needs.
Thank you, Mr. Morgan. I'm going to go with Manager Valadez, and I see your hand, Chair Greenberg. Manager Valadez, did you want to go?
quick. I just wanted to make sure that the teams that we have working in these particular areas that we've outlined here, that they take into consideration the cultures and the food considerations of those particular groups who are representative of the various, I guess, diagnoses that we need to really look at and consider, especially in light of the fact that it takes so long to try and manage or maneuver or change one's behavior, one's thinking, one's history, and not only that, accessibility to what they are used to eating and what they need to eat and what they can afford to eat, because it tends to be healthier foods tend to be more expensive. And unless we are providing them some kind of access to reduced cost purchases, maybe, the Sustainable Food Center might enter into a program with us, or some of these out of the box, maybe HEB delivering, I don't know, something other than what people, especially those living in outside the loop and in food desert areas are having to overcome in order to just get to the dadgum grocery store with limited time available. So those are also things that we need to consider for any reason. And as we go into or enter into these initiatives, make sure that we're establishing baselines so that on an annual basis, at least, we can look to see what we have actually done as far as changing the data, changing the patterns of behavior, and also changing and introducing or highlighting the successes and outcomes that we can present to the public for how we're spending our tax dollars. Thank you.
Thank you very much, Manager Valadez. Chair Greenberg.
Yes, food insecurity was something that I mentioned in passing in a comment in our prior conversation. And this is a real issue. We cannot force private entities to build grocery stores. But what we can do and should do, and I hope we are doing, is coordinating with these other programs who have as a line of service providing either free food, vouchers, getting people enrolled with SNAP, healthy food, the food that the growers have that they are providing, all these different programs that are around in Travis County in various aspects to address food insecurity. I hope that we are coordinating with them.
Thank you, Chair Greenberg. Appreciate that. Manager Jones.
Yes, I just like to piggyback off of what my colleagues have said, but a couple of other strategies we might consider as well. Even though we cannot force vendors to come into these areas, we can and should look at what we can do to help incentivize them to come into these areas. And it doesn't have to be the HEBs. I mean, HEB is a Texas staple, but there are certainly others that we might look at in other areas. In other parts of Texas, there are other vendors. I mean, I like HEB. I'm not going to say anything negative about them, but I think there are other vendors who are going to be perhaps more responsive. I've seen this done in other places, particularly in the Houston area, and we might want to consider what we as a district could do to help incentivize them to come there. Secondly, in the absence of that, one of the things, particularly in those areas where the HEBs are somewhat, and other stores, even though they're not many, incentivize how we can train individuals to cook. We talk about the shopping, which is very important. But once people get home, what we find is they go ahead and put other negative food products in the food, which make them unhealthy. So perhaps at some of these HEBs in communities of color, we can talk about having specialty, culturally appropriate cooking classes that could be headed up by nutritionists and the like. And the last thing, and it didn't relate so much to the cooking class, but I'm interested in terms of specialty care. We're a couple of the board members are very much interested in urgent care services and how we might be able to combine a location or locations, particularly in the Eastern Crescent, to have one location where that population can have access to a lot of these referral specialties and urgent care. I know this is not the purpose of this discussion to do that, but I would like to put that on our agenda to consider discussing that, because much of the data you'll see, I would venture, are referrals from these areas, and the challenges getting to them, getting the services timely, follow up on them are going to be mitigated because of the distance. So I'd like to just put those 3 points as we consider this whole issue of specialty care and Central Health role in weight loss and the like. Thank you.
Thank you, Manager Jones. Before I recognize Chair Greenberg, I'd just like to say that we are planning a discussion with regard to urgent care, and we'll definitely take up some of the issues that you outlined in your statement. Chair Greenberg?
Yes, I was going to mention that I knew we had an urgent care discussion underway. And again, back on the food insecurity, I know that there has been an effort ongoing for more time than I would like to imagine at the City of Austin to incentivize not just HEB, but discussions with various grocery stores to enter these food deserts. I would suggest that we coordinate and get back with them offline and have a coordinated effort. I know that there were some efforts to a Central Health a few years ago, but we can certainly, you know, loop back around and see where others are on those efforts, and if we can join forces again to try and incentivize. As you pointed out, Manager Jones, there are many who are in the grocery business. Beyond that, there I think are ways to incentivize the healthy cooking, and I will point out that pre-pandemic, and I don't know where we are now, but we did pre-pandemic have both a food provider with healthy food and green vegetables that was coming to Southeast Health and Wellness, and we had cooking classes at Southeast Health and Wellness. Again, with the pandemic, I see Stephanie McDonald nodding yes. Maybe Stephanie, you can elaborate.
We have partnered with Fresh Start, and those there are other programs right now during the pandemic where Fresh Start is delivering directly to people. Right. And we also we have had cooking classes at Southeast Health and Wellness Center continue. They are, run through community care, and we really are working with community care patients in those. And I know we had one fairly recently.
Thank you, Stephanie.
Can I just advocate on that one thing? I think that is great. I think we should continue that. But I was thinking in terms of cooking classes actually in the grocery store, right? Where people will shop, because they'll take those SNAP cards and benefits and others to those stores, and it'd be helpful for them to see how to shop and how to prepare the foods right there as incentives to go forward. That's what I was talking about as well.
Yeah, I completely agree. An issue is getting those grocery stores where they live, but I completely agree. If we have the grocery stores in proximity to do that, yes.
Thank you. I'll go with Manager Valadez and then Manager Musaiti.
Mine is very, very quick.
Thank you.
Our former treasurer, Rosie Mendoza, is now the financial head of Fiesta. And so please reach out to her and see what it is that they may be able to do, because they don't only deal with Mexican ethnic foods, they deal with lots of other cultural commodities. So please talk to Rosie. Thank you.
Thanks, Manager Valadez. Good information. Manager Musaiti.
Thank you. Just 2 points. One related to Manager Jones. There has been many evidence-based studies that documented to improving access to healthy foods working in grocery stores, especially if you want to increase folic intake or whatsoever, especially for some subpopulations. So there's a lot of strong evidence there. That's what I wanted to mention that. Second part, when we were trying to really modify a behavior, especially for our community, and what you're doing is tackling on multiple levels, the individual, the community, and the system level. So in order for us to really change the behavior with education, with providing easy access, and making the system easy and accessible for those who need it. Thanks.
Thank you, Manager Musaiti. Any other questions or comments before I go on to the next agenda item? All right, seeing none, I'd like to bring up agenda item number 3, receive an update on the data analysis of demographics and health disparities among the Central Health patient population. And Sarita Clark-Leach and JP Eichmiller will be presenting.
Hi there, can you all see my screen?
I can see your screen, JP.
Okay, great. Good afternoon, everyone. We have a great deal of rich and detailed information to go through, so I'm going to move rather quickly so that Sarita and I have time to answer any of your questions. First, I am going to focus on updates to our ongoing demographic analysis, which continues to evolve and expand upon the findings from the demographic report we presented to y'all last year. These demographic updates will focus on Central Health's enrolled population, that is MAP Basic, and sliding fee scale enrollees. And Sarita's disparity analysis, which will follow, will focus on the served population. So the first thing I'm going to do is go through the highlights of our demographic findings, and then I will do a quick run through of some samples of maps and charts which fed into this analysis. So overall, Central Health's enrollment decreased by about 13,400 enrollees between 2019 and 2020. If you look at the subpopulations, our year-over-year decrease for MAP enrollees was about 5%, or 2,400 enrollees, whereas our year-over-year decrease for MAP Basic was much more significant, about 12%, or 10,400. However, if you look at the rate of dropouts between those different programs, they're very similar. So what that tells us is we lost reoccurring enrollment at a similar rate. What we didn't gain was as many new MAP Basic patients as we did in MAP. So we also found, not surprisingly, Latinos represent the overwhelming majority of our enrolled members. And this is true among MAP Basic, sliding fee scale. This also holds true geographically. Latinos represent the racial ethnic majority of enrollees throughout most of the county, with a few exceptions in central Austin and scattered portions of western parts of the city and county, where our overall enrollment is low. Our total Latino enrollment is approximately 10 times that of our Black enrollment and about 6 times that of our white enrollment. Non-citizen MAP members were the actual only demographic subset that increased enrollment in 2020. So of course, with the pandemic, not surprisingly, as we mentioned earlier, we lost a lot of enrollees year over year. Our total non-citizen enrollment is actually greater than our citizen enrollment in both years that we've been recording this. And our citizens are nearly twice as likely to drop out of enrollment as our non-citizens. Spanish speakers enrolled in greater numbers and retained their membership at greater rates. So if we look at it by race ethnicity, we also see that our Black enrollee population drops out at the highest rate, about 42%, followed by whites at 38%, and the lowest grouping Latinos at 28%. The rate of homeless members dropping out of enrollment was the highest of any demographic subset. We were and are aware that our homeless population was one of the hardest hit by the pandemic. Anecdotally, this data tracks with what we have been hearing from our primary care providers. And we can also report that in FY21, we're seeing a recovery in the homeless enrollment, especially during the past several months. The rate of homelessness is much higher among our Black and white populations enrollees than our Latinos. We can also report that our homeless enrollees are overwhelmingly US citizens, 92%, and English speaking, also 92%, and male, 72%. Non-citizen enrollees tend to reside in concentrated geographic clusters. The areas with the greatest concentration of non-citizen enrollees include unincorporated North Travis County, Runberg, St. John's, Colony Park, Dove Springs. Conversely, the Travis County Correctional Complex has the highest enrollment of citizens, which is about 2,700, and is 3 times higher than any other census tract of citizen enrollment. Okay, so I'm just gonna run through some of these maps and charts that fed into this analysis. This is the map of our 2019 enrollment. This was the first time Central Health had the capability to develop something like this, actually geolocating and mapping all of our enrollees by census tract. So now we are building upon this. We've added the FY 2020 enrollment numbers. And so what this gives us, of course, is the capability of looking at this data. This map, for instance, shows where we saw the greatest decreases in enrollment year over year, with the darkest red being those areas where we saw the most significant drops. Likewise, we can look at where we actually saw increases in enrollment. Of course, these numbers aren't as large as our decreases, but we did see some areas to the northwest and northeast with moderate increases. We're also now able to track patient enrolling movement throughout the county and even outside of the county year over year. This image with the map removed, the underlying map of Travis County removed, shows the movement of every enrollee who changed addresses between 2019 and 2020. In case you're curious what this dark area is, in the center of this represents the I-35 corridor. So most of the enrollees who move tend to stay in close proximity of I-35. So with all this information and the data from the previous slides, we're now able to look at specific communities and develop a better understanding of how and why changes in enrollment are occurring, such as, are people moving out? Are they moving in? Are they just dropping from our enrollment rolls? We're also now monitoring and recording the year-over-year changes in the demographics of our enrollees. And this includes the citizenship status, homelessness, preferred language, and race ethnicity. We're also, in these third columns of these charts, we're able to examine the demographics of those who dropped out or did not re-enroll in coverage. For example, these bar charts in the top left show that while the majority of our enrollees are non-citizens, which is in this light green color, the majority of those who dropped out were actually citizens. We can also look into the subpopulations for further analysis, such as these charts showing the citizenship, status, gender, language, race, ethnicity of our homeless population. We can also take that data from those previous charts and look at it through a geographic lens. This is the distribution of our Latino enrollees by count. As you can see, the darker areas are where we have the greater concentrations, areas like Dove Springs, Del Valley, Montopolis, Hornsby Bend, Colony Park, and Runberg. The counts of the Latino enrollees, as we mentioned earlier, dwarfs that of other demographics. As you can see, these counts here going in this highest range, 1,200 to 2,500. Compare that to the highest count of white enrollees for any census tract is 290, and the highest for Black enrollees of any tract is 240. We also calculated this by percentage as well. The previous was total counts. We also did by percentage. And to be clear, these percentage ranges are indicative related to the Central Health's enrolled population, not the total population of the area. So for example, in the areas with the darkest green, if Central Health had enrolled 100 residents, that would mean 72 to 86 of those residents would identify as Latino. As you can see, Latinos represent the majority of enrollees throughout most of the county, with exceptions in Central Austin, scattered portions of West Austin, Travis County, where the total enrollment is also very low. We did this throughout our different racial and ethnic groups. Here we look at the white enrollees. The highest concentration is right here, this tiny census tract that houses the Travis County Correctional Facility. Concentrations of white enrollees is fairly well dispersed throughout the county, including areas bordering other counties. Here by percentage, the areas with the highest rates of enrollees are also among those with the lowest total enrollment, such as Central Austin and Barton Creek and Travis Heights. Top two census tracts total count for Black enrollees, the Travis County Correctional Facility, as well as Colony Park. Black enrollment totals are very low, meaning less than 25 per census tract in all areas west of Mopac, with the exception of Anderson Mill. Highest rates of Black enrollees continues to be in East Austin neighborhoods, including Pecan Springs, Springdale, MLK, Rosewood, Central East Austin. And this is more recent data. We also pulled our totals for Asian enrollees. These counts are significantly lower than any of the other racial ethnic groups. However, if we wanted to know, as we can see, northeast Travis County areas around Pflugerville and unincorporated areas to the north or south of it are where we had the highest counts of Asian enrollees. And similar to our white enrollees, we don't really get significant percentages of Asian enrollees except for in areas where we have low total enrollment. We also pulled this data by language. This is the Spanish-speaking enrollees. And we also did it, excuse me. We could also look at this by predominance. This map shows for each census tract what is the majority race ethnicity group. As we mentioned earlier, the Latino population is the majority in virtually every area, most of the areas of the county, and not only in the east, but in the west portion of the county as well. Again, these are the top line highlights that we talked about at the beginning. I won't go over them again for the sake of time. Just to give you a little preview of next steps, we're going to continue our neighborhood level analysis of the year-over-year enrollment changes, using not only our data, but some data pulls from the ICC, which we're hoping can enrich our understanding of changes over time. We're updating our databases with the same Claritas data that we use for our demographic report with 2021 estimates and 5-year projections. This will include some new unemployment data sets that we didn't have before. And we're going to use all this information to inform our strategic systems planning for the remainder of the year. And finally, just like to thank Sarita and her team for all the effort and work to really galvanize and bring this information forward to you. And with that, I will pass it forward to Sarita.
Thank you, JP. We'll now discuss chronic disease in our population with a focus on diabetes and hypertension. Those diseases were selected because they're two of the most prevalent in our population, and if unchecked, can contribute to a host of more complex comorbidities and complications, including but not limited to heart disease, including heart failure, kidney disease, including end-stage renal disease, neuropathy, vision loss, and amputation. And in the interest of time, I won't delve into the details of our obese population since John previously presented on some of those data. So we'll start with hypertension. Here's a look at hypertension stats disaggregated by race. This graph illustrates the fact that while a greater number of our MAP and MAP basic population who identify as white are diagnosed with hypertension, prevalence is higher within the Black, Asian, and other populations. For example, relative risk calculations indicate that Black enrollees have 1.7 times the risk of having hypertension when compared to the general population, and Asians have 1.34 times the risk, while white enrollees are 8% less at risk for the diagnosis than the overall population. Looking at hypertension stats from an ethnicity perspective, you'll note that non-Latinos have 1.35 times the risk of having hypertension in the general population, while Latino enrollees are 7% less at risk for the diagnosis. Looking at stats relative to sex at birth, we note that males have 1.15 times the risk of having hypertension than the general population, and female enrollees are 11% less at risk for the diagnosis. And finally, looking at these populations from a residence status, again, while a greater number of people who are not homeless have a hypertension diagnosis because they compose about 90% of the total population, homeless enrollees have 1.51 times the risk of a hypertension diagnosis than the overall population. We'll now move on to diabetes. Looking at the data disaggregated by race, again, we see that although a greater number of our white enrollees are diagnosed with diabetes, Black enrollees have 1.21 times the risk of having diabetes in the general population. That risk is even greater for our Asian population, who have 1.33 times the risk. And while white enrollees are 8% less at risk for a diagnosis than our general population. From an ethnicity perspective, you'll note that Latinos have a higher number of people diagnosed with diabetes when compared with non-Latinos, and they also have 1.7 times the risk of having diabetes than the general population. Non-Latino enrollees are 8% less at risk for the diagnosis. Moving on to sex at birth stats, you'll note that a greater number of women are diagnosed with diabetes and have a higher risk than for the disease compared to men. And finally, diabetes impacts a greater number of our non-homeless population as they compose about 90% of our total population. The diabetes prevalence is also higher among this group. So now we'll take a look at, while we focused on diabetes and hypertension because of how they impact our population and their long-term implications, they weren't the only chronic conditions we examined. Here are a few of those conditions. Some of you may have seen this chart before. We examined 8 major chronic conditions, again, because of their impact on morbidity, quality of life, and mortality. This table shows relative risk for each chronic illness broken out by demographic attributes we looked at in the previous slides. Blue indicates higher risk for the disease. The darker the blue, the greater the risk. Gold represents a lower risk. The darker the gold, the lower the risk. You'll note that in terms of race, Black and Asian enrollees have a higher risk than the other population for most of these diseases. From an ethnicity perspective, non-Latinos tend to have a higher risk for most, and homeless populations are at a higher risk than the general population for these conditions. This next slide is a reference table with numerator and denominator for prevalence rates for a reference population in the previous slide. And then we've been asked to contextualize our prevalence rates with community data. However, these data are scant and they don't provide an apples to apples comparison. You can read how the data capture, and again, in the interest of time, you can read how the data capture methodology for these community prevalence rates differ from ours, as this presentation is in the backup packet. And now, looking at prevalence from a geographical standpoint, this heat map is included in our demographic report and will be updated soon. And it shows prevalence for chronic conditions in 12 focus areas throughout Travis County. It illustrates that East Central Austin and Leandro Lago Vista are areas with highest prevalence for most of these diseases. East Central Austin has the greatest number of people impacted by these conditions, while Leandro Lago Vista has a much smaller number of people impacted relative to the high prevalence. So some key takeaways from these data. Hypertension and diabetes are two chronic conditions with high prevalence in our MEP and MEP basic populations, and also including obesity, but that wasn't focused on here. Chronic disease prevalence are generally higher among Black and Asian race groups in terms of ethnicity, people who don't identify as Latino, in terms of sex of birth, male, in terms of residence status, homeless populations. Also, though not presented here, we noted that clinical measure performance relative to outcomes that speak to appropriate management of chronic conditions are generally below average for non-Latinos, people who don't identify as white in terms of race, and the homeless population. The fact that prevalence rates and outcome measures are generally more favorable in our Latino population may speak to the fact that we have come a long way in our engagement of that community. Credit certainly also needs to be given to our local community organizations in that regard. And while I'm not implying that there isn't more work to be done in improving the health of our Latino members, we should use lessons learned from their more successful engagement to foster a similarly effective engagement with our Black, Asian, and other communities of color. Again, recognize that while these race and ethnicity categories present communities as a monolith, we understand that the different engagement strategies may have to be undertaken for subpopulations in these categories. Our next steps, we'll continue to refine this analysis, including a look at prevalence for multivariate populations. These are just examples, they're not necessarily the deeper dive we'll take, but for example, Latino women, Black women, white homeless men. We may, again, look at citizen status relative to some of these subcategories as well. We'll update the geographic prevalence mapping, and we'll continue to work to acquire mortality data from DSHS or IPH, as we understand that mortality certainly is an important metric for us to be aware of in the population. Thank you.
Thank you very much, Sarita. Excellent presentation. I would like to open it up for questions from our board members. I'll take Manager Brinson first, and then I'll go to Manager Jones.
So I'm certain that you have this data, but do you know by age what our enrollees are? And then by age, their different illnesses, the average age, for instance?
We do, and it does, of course, change by the disease chronic condition we're looking at. But in general, our demographic tends to be younger than what is usually reported out by the city, right, in terms of prevalence. So we don't have that population that is, we don't have a large 65 plus population. Our folks tend to be between the ages of 30 and 54. And again, the breakouts, chronic illness are more prevalent in older populations, and that doesn't differ in our population as well. And we understand that some of the better outcomes or lower prevalence rates that we see for our Latino population can be attributed to the fact that they're also a younger population in our mix. So.
Thank you.
Thank you, Manager Brinson. Manager Jones.
Yes, thanks, Sarita. As always, very good information, really appreciated. A couple of questions. One is, in your profile of indicating that Blacks are 10 times more likely to have higher rates of, I think it was hypertension. That's very interesting, and I'd be interested at a later date of talking a little bit more about that data.
So I'd like to correct, so it wasn't 10 times, and I'm sorry if I said that, I misspoke. It was more like 1 point, I'll have to go back and look, but no, not 10 times.
Okay.
None of these rates were 10 times higher.
Okay, maybe I misunderstood that.
Sure.
Well,
it's 1.75.
It was 1.75 times,
okay.
right?
Okay, I thought that was 10 times for something. Perhaps I got it confused. My second question related to when you did your profile of populations, Did they, in terms of, I forgot what the category was, forgive me, I didn't write it down. Are we talking specifically about sliding fee scale, MAP, and MAP basic participation? Are we able to dissect out of those by race and ethnicity? In other words, by race and ethnicity, MAP users, sliding fee scale user, and MAP basic and MAP clients?
We can, but you'll understand that because those populations traverse those different payer categories, and these really are a people metric. It's not necessarily an encounter metric. It just makes it a little more complicated. We can report on those. But again, someone could potentially have MAP for 6 months and then transition to sliding fee or vice versa within the same year. So as you're looking at prevalence rates, it becomes a little complicated. But and so we did the whole population together just because it gets more complicated than that.
No, and I'll follow that. I was just trying to get at, is there the likelihood of particularly African Americans having a higher sliding fee scale participation or MAP population? Because that's what I was trying to get at.
I see. And, you know, I'm always hesitant to sort of throw out numbers off the top of my head. So I can get those numbers back to you, Andrew Jones.
Okay, and then one last question, and I'll end. In your profile of race and ethnicity and of the chronic diseases, I noticed that when you looked at the race, African Americans and Asian had higher rates, but when we went over to we looked at the ethnicity, Hispanics had higher. And I guess my question goes to, is there any way to look at that question of race versus ethnicity issue in terms of mortality? Because therein lies a major question in terms of how we approach service delivery in our community.
Right, and
question, so I just didn't know.
Sure. Sure, and we certainly know that, you know, as they're reported, as we're looking at these data, race and ethnicity actually get conflated in some of our data sets. So really what we have in the data set are Hispanic or Latino, and then everything else is non-Hispanic. So it'd be non-Hispanic Black, non-Hispanic White, and so we leveraged multiple data sources to come up to be able to separate these categories out. But we're rethinking that and considering whether we should report them as they're conflated, right? To include Hispanic as a category within those. As one of the different categories broken down by race, ethnicity. So there are lots of different ways we can look at these data. I don't know if that answers your question, but I understand, you know, the complexity of what you're asking.
You were muted, Manager Jones.
Yeah, thanks very much. I'm just trying to get at, are there strategies we can look at within race and within ethnicities where they cross over, that we should look at strategies to look at those populations as well?
Sure, yes. Yes.
And
we'll pursue that.
Thank you very much, appreciate it. Before I get to you, Manager Valadez, I wanted to let the group know that Manager Usaitif had to leave the meeting. And so Manager Valadez.
What I'd like to know is more to the question of those that have dropped from MAP and MAP Basic, and in light of the fact that we went through a pandemic, that we went through this horrible winter storm period of time, and other issues. What I'm still trying to get to is us expanding our MAP enrollment to the year long, as opposed to the every 6 months, or us having to take action to not drop anyone due to specific issues, a crisis. You know, I really, Dr. Bell and members of the Central Health Board, I really do believe that a lot of times people drop because we're dealing with this lowest FPL percentage, you know, the 200 and below, they're the ones that are having to move so much and so often because they don't have access to affordable housing. And so they're looking at either month-to-month contracts or every 6 months contracts. And so when they get notified it's time to enroll or for your appointment or blah, 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 they may have already moved. And I don't know how well we are actually staying on top of people's addresses in light of the fact that many of them don't have doctor visits unless it's an emergency. And it could be once every 6 months. It could be on an annual basis, depending on their condition or their health. And so in order to get to trying to maintain as steady a population, a membership in MAP and MAP Basic, I'd like to know whether at some point in time we're going to really look at that and whether or not, for the purposes of this discussion, they actually looked at reasons for people not having re-enrolled or been dropped. Can anybody tell us whether they were following that or capturing that to be able to use that as a justification for no longer being or actually accessing services?
Thank you, Manager Valadez. Any staff member want to address that question? John Morgan, please.
If I could address overall enrollment, Dr. Bell, I just wanted to put a finer point on JP's analysis that he was talking about for overall enrollment. We absolutely saw decreases in enrollment over the period of the pandemic, and appreciate you also acknowledging the winter storm. I do think that had a very significant impact on our patients. We have started to see in recent months that are not included in the time period of this particular analysis, overall enrollment for both MAP and MAP Basic trending towards recovering to pre-pandemic levels. We hit some low points in terms of overall enrollment in our programs back in November, and since November we have started seeing a trend of increasing enrollment. So we're happy to see that. As you know, there were a lot of steps taken during the pandemic to try to ensure re-enrollment or continuous enrollment. The action this board took along with Ascension Seton to make some accommodations for automatic re-enrollment and extensions, as well as the creation of the online application and the enhanced services available through the call center. So just wanted to touch on that portion of the question. I'll defer to others.
Thank you, John. Mike, I saw you had taken your microphone off. Did you want to say something or?
Yes, and I think too, you know, one of the improvements and quite frankly, one of the, what I would say is temporary solutions, it's certainly not a permanent solution, is, and you think about the staffing, we've increased the number of staff, enrollment and eligibility. We have a call center now. Hasn't been operational yet for a full year, but is certainly made vast improvements even in the early stages in terms of upscaling its operations. And so being able to reach out to people now in ways that perhaps we haven't been able to do before, especially those that we know that have chronic conditions that need to be managed and kept within that continuum of care that was presented earlier. You know, we have a way to keep people continuously enrolled. Now, obviously, there's going to be some individuals, as you pointed out, Manager Valadez, that they move. Maybe they change phone carriers, or they're not able to afford their phone service. Right. And so there's folks that obviously fall through the cracks in that regard because we can't locate them, or there's certain life circumstances that they're not able to reach out to us, even by telephone. So there are some challenges there that we need to continue to work on. And then I'll also state that with continued outreach, and so let's say folks that maybe have never been in MAP before, or have never enrolled, but I think that with continued outreach and just continuing to get the word out there about the medical access program and what it can do for you in your life is going to be important to keep that continuous enrollment and to keep that top of mind awareness. The programs are working through partners to help amplify that message. So there's a lot more work that we need to do, but I think there's some big steps that we've taken within the past 12 months.
Thank you very much, Mr. Giesland. Sarita, did you want to add something before I recognize Manager Valadez again?
Sure. And Manager Valadez, I wanted to let you know that our team has been looking at those dropout rates, trying to understand the population, why they're dropping out. And it's really, it's a little tough to come up with anything conclusive, especially during this period. At first, when the pandemic started, we were looking at, we designed a model to look at, dropout rates relative to, or enrollment rates relative to what the unemployment rates might be. And we're seeing that there wasn't necessarily, a real correlation there. We looked at dropout rates for citizens versus non-citizens, for homeless versus non-homeless, for, substratify the population and really try to get at who was dropping out and perhaps come to a why. But I have the feeling that, as was stated here, enrollment for some of these populations is very much dependent on their need to utilize a health service. Right. So they'll enroll when they need to utilize. And if those services aren't available or if they're not presenting to the sites of service during a pandemic, then they probably won't enroll. And that might be what's attributed to that.
Thank you very much, Sarita. Manager Valadez.
Yeah, thank you, Sarita, for saying that, because one of the things that in the conversations over the last 30 years, but more recently, in the last year and a half, with Spanish-speaking populations and so many that I know, you're going to have more people enrolled, the non-citizens enrolled and maintain their enrollment because they don't have access to anything else and they need it. With respect to the 65 plus, as Cynthia was asking about, in the Latino population and my population, you're going to find that they're going to be eligible for MAP and Basic because they're not eligible for anything else. They're not eligible for Medicaid. They're not eligible for Medicare. They're not eligible for anything. So they maintain that they try to hold on to what is offered to us by MAP or MAP Basic because that's all they have. And so that's why I'm always so concerned about the populations that we are not reaching or that are not accessing our services. And whatever it is that, if we need to put up, Ted, more billboards in those targeted areas, you did a great job on showing us where the demographics, where they're located. If we could put up a billboard, in each of those areas, at least along a major thoroughfare, enroll in MAP, call this number, or just something very simple. We don't need to get into anything else. Just say that. Enroll in MAP. If you need health services or you need, si necesitas, if you need this, just call this number, 512-478, whatever. That's what we need. Something as simple as that, I think, may help. Reaching out and hiring people to go do these jobs or contracting with contractors who are going into the area is definitely needed and necessary for the distinct populations so that they have someone that looks like them talking to them. But for the rest of it, I think simple campaigns like a billboard do a lot. Radio and television ads are expensive. That airtime is expensive, but the ads, those billboards, I noticed the billboards, and I can't see, but I noticed the billboards, but, and I think that really people do because they really get upset when they're dropped from MAP. You can't imagine how upset people are that have had to move outside Travis County lines and are no longer eligible for MAP. That's a devastating blow for them, but it's one that they have to accept because they can't afford to live in Travis County. So
thank you very much, Manager Valadez. Chair Greenberg, please.
I want to thank the entire team for this presentation and for continuing to provide more demographic information, more analysis, more detail to improve upon it. This is so important to our work to have this kind of demographic data and to be able soon to have trend analysis. We can't do that now on most of it because we just have 2019 and 2020, but going forward to be able to have a trend analysis that we can do from this demographic data with continuing to improve all that we're doing, whether it's by certain subsections of our population, the geo mapping. I found particularly useful the in and out. It looked like kind of a string, right? That was a new feature that I saw. So thank you, and we look forward to more to come.
Thank you, Chair Greenberg, and I do echo Chair Greenberg's thanks for your presentation and the work you do. The data that you provide us is just totally invaluable, and we really appreciate it. It is 3:23 by my clock, so I want to move on to the next agenda item. Agenda item number 4, receive an update on FY 2021 and FY 2022 strategic priority to develop an equity-focused system of care plan, including information about the consultant selected and grant funding to support the work. Monica Crowley will be presenting.
Thank you, Chair Bell. This is an update on 2 key areas around this work. First is the request for proposals for a consultant to support the equity-focused Strategic Healthcare Services Plan, and that's the long-term comprehensive systems planning work that was mentioned in the earlier presentation. The earlier presentation was on the immediate recommendations. This is on that longer-term next phase. And the second one, the second part of this is on the conditional grant that was awarded to Central Health for up to $600,000 by the Episcopal Health Foundation in support of this work. I'm going to start with the update on the $600,000 grant. And you heard about that in March when Elena Marks, the CEO of Episcopal Health Foundation, presented to the board about the grant. And the grant recognized both the high quality of the initial planning work that had been completed by Central Health and represented a validation of this equity-focused systemic approach that was being proposed to be undertaken by Central Health staff and the board, and the importance of that work to the development of a comprehensive, high-functioning system of care to serve the current and future needs of the Travis County residents with low income. 2 conditions were required by Episcopal Health Foundation to release the funds to Central Health. And I apologize, I have a dog whining behind me. So sorry about that. I am looking forward to being in the office in person at a meeting in the future. So 2 conditions were required, only 2 conditions were required by Episcopal Health Foundation to release those funds. The first condition is that the Central Health Board accept the grant. That also is a requirement for Chapter 281, and that Central Health conduct a procurement process and select a consultant to assist with this work. And Central Health has gone through the procurement process and has selected a consultant. And we are going to be requesting at the June 30th board meeting that the board take action to accept the grant from Episcopal Health Foundation at the June 30th board meeting. Now I'm going to go on to the second part of this short item, and I kind of am bearing the lead here, and that is the selection of the consultant to support us in the systems planning work. And this happened earlier this week. After a robust procurement process, Central Health procurement team provided Guidehouse, which is formerly known as Navigant Consultant, notice of intent to award a consulting services contract to support the next phase of the systems planning work. We are in the very, very beginning phase of negotiating that contract, and we will be coming back to the board with the proposed agreement at a later date. And just as a reminder to you all, this consulting work is, the consulting support is essential to assist staff and you as board members in the next phase of this work to develop this comprehensive plan, and it includes a number of key elements. The first one is assistance conducting a safety net community needs assessment focused on the low income population in Travis County that we currently serve, but also Manager Valadez, Manager Jones, to the point you were getting at the population that we could be serving today, but that we are not. And one of the things that the consultants are going to bring with the additional people that can support this work, that can support Sarita and her team and JP and the rest of us in this work, is looking at aspects of the system where Central Health isn't directly funding services or providing care through our partnerships. So being able to look at areas where there are people that are under 200% of the federal poverty level that we could be serving, but they're seeking care from people that aren't, or providers that aren't in our network today. And that takes that takes an additional level of effort that we need this outside support for. So that is you've seen the robust kind of the expertise that we have of our data and analytics people internally, but we need this additional support to look both demographically and geographically at this need that is unmet today, and then projecting that out for the future for our planning efforts. They're also going to help us analyze gaps, network adequacy, current and future unmet need, and also health outcomes and additional health disparities in these other populations that we aren't directly serving today. And they're going to do this by type of service and by geography. They're going to help support Ted and his team in more intensely doing more intense community engagement, including work groups, standing up advisory committees, standing up additional stakeholder committees, conducting additional surveys. We've used our Promise and CAP surveys that we do every year and are conducting now, but we're still going to do that work, but this also adds additional resources related to surveys, focus groups, community conversations that we need for this intense planning effort. That it's even more community engagement than the high level of community engagement that Ted and Yvonne and their team already do. And then they're also going to provide additional project management support to the development of this longer term plan, working with staff and with Dr. Bell and the members of the Strategic Planning Committee as we use the Strategic Planning Committee to help develop a recommended plan for consideration by the board and hopeful adoption in December of this year and January of next year. So the key things to come is we're going to be recommending action to accept the grant at the board meeting later this month. Currently, we've begun negotiations with Guidehouse on a contract around these services, and we'll be bringing that agreement back to the board at a later date.
Thank you so much, Monica. That was a mouthful, to say the least. I wanted to let the members know that since this is coming back to the May board meeting, you will have another swing at this for questions, but go ahead. I'm sorry, the June board meeting, which is the 30th of June. That's what you were trying to tell me, Mike, right? Okay. The June 30th board meeting. So you'll have another strike at this initiative. So if you could make your questions as concise and as quick as possible, I would really appreciate it. So open it up, Manager Valadez.
Mine's very quick. And Monica, and you don't have to tell me now, but if you could send it to us as a board, the demographic breakup or the diversity of that organization at the top, I'd be curious as to know what it is and to see, basically that's going to tell me a lot about the organization, and basically the demographics. They're bored. That's it.
Okay, thank you, Manager Valadez. Manager Jones.
Just a follow up to what Manager Valadez said is not so much the makeup of their leadership, but what kind of work they've done in the past, a little bit more about them. I'm not as familiar with them as others are. So if you could provide some more information about that, it would be appreciated.
Thank you very much, Manager Jones. Not seeing any other questions, I would like to go to agenda item number 5, which is to confirm the next Strategic Planning Committee meeting, date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, August the 4th, 2020 at 1 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. I do want to let the committee know that we will be bringing back the Eastern Crescent subcommittee, which will be chaired by Manager Jones. And that will start at, is it 1? Okay, so it's going to start at 1, and then the strategic planning will follow that Eastern Crescent subcommittee meeting. So we will be discussing the agenda items for the Eastern Crescent subcommittee meeting at the executive committee meeting on June the 30th. All right. With that, I'm ready to accept a motion for adjournment. I have a motion by Manager Valadez. I have a second by Chair Greenberg. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned. Thank you, managers. Sorry we went over. Appreciate your time.
Are we having our retreat this afternoon also?
Yes, I'll see you at 5.
Okay.